This PowerPoint is going to review the different rhythms of EKGs. Your main focus is to recognize the various rhythms. Remember, if you are seeing these in your sleep lab, you're going to keep your study running, you're going to respond appropriately, and then you're going to document thoroughly. So let's get started. When performing sleep studies, the EKG recording tends to be the most ignored channel. Clearly, it does hold significant importance because that is the body's pump. It is pumping blood to all the organs. Technicians tend to get caught up in observing the sleep stages and respiratory events, and we forget about the cardiac functioning. Realistically, you have to keep in mind, our job is to gather accurate and reliable data. These patients sleep like this every night of their life without someone watching them and seeing these different cardiac rhythms occurring at night. So although there are some life-threatening rhythms, you need to be able to identify them. You need to know how to respond in those situations. Rarely are they going to occur. Predominantly, you may see some abnormal rhythms that are not life-threatening. In those situations, you want to document that you found them. You can document what epoch you saw them on, and if they occurred throughout the night or only at one time. Also, if you recognize that they continue to occur along with some other event, like an apnea or something. Let's go on. Just to review a little bit about cardiac anatomy and function, we have two atria, the left and the right. These are the upper chambers in the heart. So the right atria is where blood returns to the heart from the body. Coming from the superior and inferior vena cava, the blood dumps into the right atrium. The right atrium is thin-walled. Both atriums are thin-walled actually, and they are considered to be reservoirs for blood. So they hold the blood, and along with the electrical conduction, the heart muscles respond appropriately, and the blood passively flows into the right ventricle. Then the right ventricle is a small pump, and it pumps that blood into the pulmonary artery, which then ushers the blood around the lungs. This is where gas exchange takes place. The blood dumps off CO2 into the lungs and picks up O2 from the lungs. From there, the blood then goes to the pulmonary vein and returns to the left atria, another thin-walled reservoir. The blood passively flows into the left ventricle. This is a larger pump, and that pumps the blood out to the body. Let's go to our next slide. This one just focuses on the ventricles. Remember, these are the lower chambers in the heart. The right ventricle is a thin-walled pump, and it pumps blood to the lungs. The left ventricle is a thicker pump, stronger pump, because it has to push that blood all the way out through the body. It is the pump of the left ventricle which produces the pulse when you feel someone's wrist. Let's go on. Now, to understand why the pump maybe isn't working correctly, you have to understand just a little bit about the phases of the electrical activity which trigger the pump to move. So we're talking about two things. The plumbing of the heart is the pumps, and the electricity of the heart is what makes those pumps work. So starting at the top on your left hand, polarization is when the heart is ready. The heart is relaxed, but it's ready to receive an electrical stimulus. Depolarization is when the heart muscle is contracting, and this is going to cause blood to flow. It's going to push the blood to the next area. Repolarization is considered the recovery. Your contraction is complete. The heart is returning to a state of readiness. It's relaxing, so then it can go back to the polarization phase. Now let's take a look at our picture on the left, and this kind of shows what's happening with the electrical conduction with what you're seeing on your polysomnogram when you're looking at your EKG. So we first have atrial depolarization. That means the atria muscle itself is contracting. And during this time, we see a P wave occur on our EKG, and you can see that circled on your diagram. Next, you have a delay at the AV node. So what that means is the The atria depolarized, the signal was sent, that atria contracted, and the electricity then goes to the AV node, and the AV node just holds that electricity there for a brief time. And again, it's circled on your diagram, so you see a flat line on part of your EKG. It's called the PR segment, and that is when there is a delay at the AV node. Next, we have ventricle depolarization. So we had our atria contract, then the electricity pause at the AV node, then it goes to our ventricles. So this is when our ventricles are contracting. During this time, it makes the QRS complex, and that is the wave you see circled on your picture there. Next, you have ventricular repolarization. This is recovery of the ventricles, and this forms what we call the T wave on our EKG. And then lastly, we have no electrical activity, also known as polarization. This is where the heart's relaxed, it's ready to receive an impulse. The next step will then be to go back to atrial depolarization, and then the process just repeats. Let's take a look at our next slide. So here is another description, or depiction I should say, of what we just covered. And I like this one because it shows you in the heart where the heart muscle is contracting and where it's relaxing, because the heart muscle is doing it as the electricity is passing through it, but the whole heart doesn't contract at one time. So let's take a look. We're going to start with number 1, and that is the top left-hand heart picture 2. We have atrial depolarization. So this causes a P wave on our tracing, and you see in the picture of the heart, the red is showing that that part of the heart is contracting, and that signal is being sent throughout the atria. Number 2, we have atrial depolarization complete. So all of the atria has now been contracted, and you see that our P wave is completely done, and the waveform is back down to baseline. Next, we have number 3. This is where the ventricles begin to contract. Now notice in your picture of your heart on number 3 that the atria are green. This is because in the atria, they're already repolarizing or relaxed, while the ventricles are starting to depolarize. Also in number 3, you see the yellow arrows are showing that the electrical signal goes down the middle, or the middle of the heart, and then it goes around the Purkinje fibers. So the actual ventricle actually contracts from the bottom upward. So the base of the heart contracts first, and then the contraction continues up through the rest of the ventricle. So that is number 3. It starts to contract. Then number 4, now your picture for this is on the top right of the diagram here. And this is where depolarization is complete. So the entire ventricle has now contracted. So you see between 3 and 4, 3, you have the Q to R interval is beginning, and then by the end of 4, we're finishing our QRS complex. Number 5, this is where the ventricles begin to repolarize, so they begin to relax, and again, relaxation starts at the bottom of the ventricles and then will work its way up. And you see now your QRS complex is complete, and you see the beginning of your T wave there. Number 6, we have complete repolarization or relaxation of our ventricles, and now we have one complete EKG rhythm. And then this process just continues over and over again. Let's go on. So with a normal EKG, like we looked at on the previous slide, the heart is going to pump normally. You'll be able to feel a pulse in your patient's wrist, and it should be of a regular rhythm. Let's go on. Now, abnormal electrical conduction, any abnormal transmission of the electrical current through the heart, that's an arrhythmia, has the potential to affect the amount of blood getting to the body. So it could possibly affect how well your heart is going to pump, or the manner in which it's going to pump. Our goal with this is just to recognize and respond appropriately to various arrhythmias. And some arrhythmias have no response from us whatsoever. We just need to recognize it and document it. Let's go on. Okay, important note when we do look at these rhythms is you're always treating the patient, not the rhythm. We're not doing rhythm strips because we do not use those in the sleep lab. We're looking at a polysomnogram. So you are unable to count your different portions of your QRS complex. More likely you are going to kind of eyeball it and recognize the abnormal rhythm. Let's go on. Okay, so this is our normal sinus rhythm. Hopefully this is what all of us have right now. With this, we have the SA node generates the impulses, which is normal. The atria and ventricles both depolarize and repolarize at their regular intervals. We have a normal rate at 60 to 100 beats per minute. Our heart pump function is normal and there is no action needed with this type of rhythm. You should be able to recognize this type of rhythm. You want to identify your P, QRS, and T wave, and they all look nice and evenly spaced. The T wave, you notice, is slightly bigger than the P wave, and that's about all there is to it. Let's go on. Sinus bradycardia. So what this is basically just a slowing of a normal heart rate, or of a normal EKG. Again, all impulses are from the SA node, like normal. Your atria and ventricles depolarize and repolarize in a normal fashion, just slower than they should. Overall, the rate is slower than 60 beats per minute. This type of arrhythmia has no effect on the heart's ability to pump blood. It's just doing it at a slower rate. There is no action for you to take. You just want to document in your tech notes. And notice these are very regularly spaced. There's just a large pause between each P, QRS, and T wave. The P, QRS, and T wave is of normal duration itself. There's just increased space between each one. Let's go to our next slide. Sinus tachycardia. Again, all impulses come from the SA node, so the pump is, or the electrical pathway is functioning normally. The atria and ventricles are depolarizing and repolarizing correctly. This is when the actual rate of that occurring, though, is over 100 beats per minute. When these heart rates get this fast, sometimes it's hard to find your P waves because they're occurring so quickly that you can't really see them. Again, this has no effect on your heart pump. It just is increasing how fast the heart is pumping. Again, there's no action for you to take, but you do want to document it in your tech notes. Sinus arrhythmia. Now, in this situation, all impulses come from the SA node. Both the atria and ventricles are depolarizing and repolarizing as they should. They're just doing it at an abnormal rate. So for some reason, the rate is not regular. So your heart pump is working fine, just an abnormal rate. Again, there's no action for you to take. You just want to document the finding in your tech notes and specify epochs when you found it. A particular point to be made with this one is if you're noticing this occurring in correlation to some other clinical event. For example, if the patient is having desaturations and every time they desaturate this tends to happen, or if they're having apnea and you find this follows or correlates with the apnea, you would want to note that in your tech notes. Let's go on. Premature atrial contraction, also called PAC. This occurs when the atria is depolarizing too quickly. The P wave can appear differently, but usually it's just seen as two closely placed beats. The heart pump in this situation is not compromised. There's no action for you to take. You just want to document this in your tech notes. So if you look in your picture, it's pointing at the P waves in each that correlates with each QRS complex, and you can notice that last one, you see that P wave barely forms. That is a PAC. The other EKG rhythms on this picture are normal. It's just that last one with the P is where you're seeing the premature atrial beat. And this is occurring again in the atria. Let's go on. Atrial flutter. This is caused from a single irritable site which initiates multiple impulses at a rapid rate. So another way to think of this is your atria are kind of fluttering instead of doing one contraction. On your strip, you're going to see multiple F waves, F referring to flutter, which replace the P's, and you'll see this as a 2-to-1 or 3-to-1 ratio to the QRS. So meaning you're going to see 2 or 3 small waves prior to seeing your QRS. So you're not going to be able to tell the difference between F waves, P waves, and T waves. It's just going to look like wavy lines and then a QRS and then more wavy lines, but your wavy lines are going to be fairly regular in their height and width. The heart rate in these situations is typically around 110, but the rhythm itself is regular. Your heart pump in this situation could be compromised, but it's not an acute situation. There's absolutely nothing we can do about it. There's no cause for concern. This person probably has it every night. Some of them probably have it all day too. Again, you want to take particular notice if this happens in correlation specifically with some other event. So if they have a normal sinus rhythm and then all of a sudden they go into flutter and then come back to a normal sinus rhythm, did something happen that caused that flutter to appear? Let's go on. Atrial fibrillation is similar to atrial flutter. The difference is this is not a regular rhythm. It's kind of the atria is quivering basically, and so the little waves before your QRS are going to be in an irregular fashion. This is when many sites in the atria are generating their own rapid impulses. The rate can be anywhere from 100 to 160. Again, your heart pump is not going to be compromised. This is not an acute situation, and there's absolutely nothing you can do about it. But you do want to document your findings, and again, is it occurring when something else happens, or do they have it all night long? Let's go on. Premature ventricular contractions, also known as PVCs. This is when the ventricles depolarize before they should. So you're having a unifocal or sometimes multifocal source in your ventricle, which is causing the impulse to irregularly originate. In this situation, your heart pump is typically not compromised significantly. However, it can lead to a more serious arrhythmia, which we're going to get to in a little bit. But this in of itself, you just want to document it. And again, is something causing it that you can tell. There's no immediate action you need to take other than you just want to keep your eye on them. Now, one thing with PVCs is they tend to have abnormal shape on your EKG. If you look at the picture in the top right, you see this is called just occasional PVCs. So you see a normal rhythm, then a PVC, then a normal QRS, then a PVC, then a normal QRS, then a PVC, and so on. If you look down at the bottom, you see how the PVCs are occurring every third beat. We call that trigeminy PVCs. So the picture at the top of your screen could be considered bigeminy. The one on the bottom of your page would be trigeminy. If you have 4 or more PVCs in a row, that actually is a completely different arrhythmia, and that's the one that we're most concerned with. So we'll be getting to that here in a few minutes. Let's go on. Now this is the one I was just talking about, ventricular tachycardia. Notice how the picture at the top of the screen, those waves kind of look like PVC just repeating itself. That is exactly what a PVC could possibly lead to, and so that's why you want to keep a close eye on your patient when you see one PVC. But one PVC in of itself is not a concern. It's only when you see this pattern. This is an abnormal tissue in the ventricles is firing very rapidly. Notice you can't even find a P wave on there. This patient has poor cardiac output, and it could lead to cardiac arrest. In this situation, your heart is not pumping effectively. This is life-threatening. You want to keep your study running. You want to have someone who's there with you to call 911, and you want to go try and wake the patient. If you cannot wake the patient, you want to feel for a pulse and start CPR, and then defibrillate if the patient remains unconscious and pulseless. The important part of keeping the study running is so if they come out of the rhythm while you're walking to the patient's room or while you're trying to wake them up, someone in your sleep center with you can tell you that they came out of the rhythm prior to calling 911. So you always want to keep your study running in these situations. It helps document what you've done. And once the situation has resolved, you would want to document exactly what happened. Let's go on. VFib, or ventricular fibrillation, is also life-threatening. This is where your ventricles are basically quivering instead of contracting. As you can see in your picture here, notice there are no QRS complexes. Notice your waveform, it looks like just a rugged bunch of little tiny waves. Blood is not perfusing the body. The heart is not pumping effectively. This is life-threatening. Again, keep your study running. Ask your coworker to call 911 while you go wake the patient and start CPR, and defibrillation is indicated with this rhythm. Let's go on. Asystole, also called flatlining. This results from a complete lack of electrical impulses from the atria or ventricles. So your heart is not pumping at all. Very life-threatening. Again, keep your study running, go wake the patient, and then call 911. The reason we do not call 911 right away is because you could get this line if your EKG lead came off. An important side note to this is if you have this flat line, but you have solid brain activity and breathing, then most likely your EKG tab just came off. So that is why we do not just call 911 as soon as that line goes flat. Let's go on. First degree AV block, and part of my thing got cut off there. First degree AV block is caused by a conduction delay from the AV node. So remember, your electrical pathway through the heart starts at your SA node, it goes to your AV node where it briefly pauses, and then down through the bundle of His and to the Purkinje fibers. So in this situation, that conduction is being blocked from the AV node, and you can kind of see it in your picture there. It's showing you where it's being blocked. This will have a normal rate, and the heart pump is working okay. You'll have a 1-to-1 ratio of your P waves to your QRS waves. So you'll have a P wave for every QRS. Some trained athletes might have this, and that is not of concern. There's nothing you can do about this. You just want to document your findings. Basically all it is that the P wave prior to your QRS complex is just a little bit longer than normal. So if you look at the top picture up there, you can see your P wave compared to your QRS compared to your T wave compared to the space after that. Those are almost the same length. So it just is when your P wave is to your R is a little bit longer than normal. So it's taking a little bit more time for that electrical conduction to get your ventricle to contract. Let's go on. Second degree AV block, also called type 1, also called Wenckebach. This is when not all of your atrial beats conduct to the ventricles to cause a QRS. So your atria is beating normally, contracting normally, but at some point the signal does not get sent to your ventricles. Your PR interval length will gradually lengthen until there is no QRS at all. It drops the beat. Your rate is typically normal or slow, and there's again nothing you can do about this rhythm, so you just want to document your findings. If you look at the picture on the right, on the bottom picture, it shows, we're going to be looking from left to right in your picture. Notice your PR interval is wide on the first rhythm. The next rhythm, the PR is a little bit wider, and then the next rhythm, there's no QRS complex at all. It totally drops it. And then it goes back to another P that's more normal, followed by a QRS. And then the next rhythm over, your PR interval gets a little bit wider. And then the next one over, it gets a little bit wider yet. And then the next rhythm, the QRS isn't even there. It fails. So that is what is the specific characteristic of second degree AV block type 1, which is also called Wenckebach. Let's go on. Now, second degree type 2 AV block, also called Mobitz, this is where the impulse fails to travel through the AV node or the bundle of His. So it completely blocks the ventricle from contracting. Your P waves are constant. You just all of a sudden won't have a QRS. Again, this is not of major concern because there's nothing you can do about it. This is probably patients had this for quite some time. You do want to document your findings. But how this is different from the other type second degree AV block is the other one progressively the PR interval got longer until it was dropped. With this one, you just don't have your QRS. It's not that the PR interval gets longer or anything like that. It's just all of a sudden the QRS isn't there. Let's go on. Third degree AV block. This is also known as complete heart block. Complete block between the atria and ventricles, causing complete independent functioning of the two. So they are not correlating, so the blood is not flowing from the atria into the ventricle and then from the ventricle into the next vessel because they're not coordinated. They're both contracting at different times. This is life-threatening. Again, you want to keep your study running, have someone call 911 while you go try and wake the patient. If you look at the picture with the blue arrows, it's showing you how there's, starting from the left and going to the right, you have one QRS complex, then it shows you two P waves identified by the light blue arrows, then you have another QRS complex, then you have one P wave, and then you have another QRX complex. So there's just no regular rhythm going on there. Let's go on. Okay, so sometimes it's easiest to pull these up and look at them all together. So your AV blocks are a little bit different than the rest of your arrhythmias. This is where the electrical transmission is being interrupted, and only one of these is when you really need to have an emergency and call 911. Starting in your top left-hand corner, that's your first degree AV block, and this is just where your P wave is a little too far from your QRS. It's just taking a little bit of time for the electrical signal to get from the atria to the ventricle. Going down, we have second degree AV block, Mobitz 1, which is also called Wenckebach, excuse me. And this is where you have successively longer PR intervals to the point at which you lose a QRS complex. So it takes a little bit longer each time to get that signal to the ventricle, and then all of a sudden it doesn't get to your ventricle at all. Moving to your right, bottom right block, this is another second degree AV block. This is type 2 or Mobitz, and this is where the P waves are all of a sudden they just do not have a QRS complex with them. The PR interval is regular, it does not lengthen, it's just all of a sudden you don't have a QRS complex. And our last one is third degree AV block. Again, this is where there's no association between your P wave and your QRS complex, and this is when the heart pump cannot pump effectively, so you need to call 911. Overview of the whole PowerPoint so far. When in doubt, check your patient and then act accordingly. There are flashcards in Moodle for you to practice these rhythms. You will need to be able to identify the rhythms, and if you need to take action, what action you should take. You should find these on your quiz. So use your flashcards and make sure you know the life-threatening ones. That's it.